Hello and welcome to this lecture. I'm Alessandra Gearhart. I'm a pulmonary and critical care physician, and I'm here to share with you some information on management of respiratory failure and critical illness in patients with COVID-19. My goal is to cover topics on respiratory support, also fluid management, the use of steroids, indications for empiric antibiotics, and we'll also cover some other ICU-related issues. A couple important disclaimers before we move on. Since the evidence is rapidly evolving with different studies being published every day, our only concept right now is change. So some of the information that I'll be sharing with you today may likely change as we move forward. And also there are a lot of controversies related to the care of these patients, especially when talking about respiratory support. Without going too much into the details of the epidemiology of COVID-19, since this was previously covered by Dr. Song on a prior lecture here, I just wanted to share a couple of numbers with you. So studies show that the patients that present with COVID-19 in the acute setting, about 70% of them are able to be sent home because they have mild disease or they are asymptomatic. About 30% will be admitted to the hospital, and of those, 10% will require immediate intensive care or mechanical ventilation. And about 15% will progress to require ICU or mechanical ventilation in 2 days. So just to emphasize the idea that we still have so much to learn about COVID-19, I wanted to show you the data from a study out of New York City that showed that 30% of the patients that required mechanical ventilation in that study, they did not require any supplemental oxygen when they were seen at first. And lastly, before I move on into talking about management, I wanted to show you these two figures that are critical to keep in mind when evaluating these patients and determining what type of care they need. Besides age in pre-existing conditions and also how they present to you clinically, it is also helpful and perhaps critical to understand where they are in regards to timeline of disease and also disease stage. Mostly with data from Chinese studies, we have an idea that patients will likely present to the hospital around day 7 after onset of symptoms. And most of the patients that will become critically ill, that will happen around days 9 to 15. It is also important to understand the stages of this disease that have been described. Stage 1 being the early infection, early symptoms. Stage 2, when patients start having pulmonary symptoms. And stage 3, which is the hyperinflammatory stage, that has been called a cytokine storm. Some patients will present in stage 2 and they will stay there, they will get better from there. But a minority of patients will progress into stage 3. So when evaluating them, it is important to try to place them somewhere as far as timeline and stage disease as possible. Now moving into management, we'll start with respiratory support. It has become pretty clear over the last several weeks that patients with COVID-19 are getting critically ill and dying because of hypoxic respiratory failure. As you can see from this graph showing cause of death in a study out of China, the vast majority of them, the cause of death was hypoxic respiratory failure, and in a minority, the cause of death was related to cardiac injury. The observation several weeks ago was that this disease was ARDS or ARDS-like, and we are still treating it as such in most places. But some interesting scenarios have been happening, especially in the areas with higher patient load, that is making a lot of the experts think differently. Some of these intriguing scenarios are, for example, patients presenting with a rapid progression into respiratory failure around day 10 to 15 after having just mild symptoms or mild hypoxemia for a few days. Or patients having remarkable, well-tolerated hypoxemia, and especially seen in young patients. Some patients have acute periods of desaturation with no obvious dyspnea if they have a peak of fever or stress or agitation, for example. And lastly, the report of this non-recruitable ARDS, or patients that we were expecting to get better on the ventilator on positive pressure, but they actually get worse. The example I have here on this image is a CT of the chest of a patient that was initially breathing spontaneously, and that's the CT on the top. Patient was hypoxemic and was placed on a ventilator with a PEEP of 5, which is normally where we start at. And patient progressed to become worse, became more hypoxemic, and the implicates actually progressed. Those scenarios are bringing up some controversies and some unanswered questions, such as, is this condition different than anything that we have seen before? Why are patients so profoundly hypoxic with variable degrees of tachypnea or respiratory fatigue? Are they being intubated too early, or are they being intubated too late? Why are some of them doing worse on mechanical ventilation? And doing all of this while balancing safety and effectiveness of all of the methods that we have to help them. Just about 10 days ago, Doctors Marini and Gattinoni, they're well respected in the world of critical care and mechanical ventilation. They published an article in JAMA explaining a little bit more about CARDS or COVID-19 ARDS, so we can try to understand the mechanism of why these patients are presenting so differently, so we can hopefully understand how to care for them better. They explained that the injury that the virus causes is primarily to the vascular endothelium as opposed to just air spaces, and they proposed 2 different patient phenotypes that were seen. The first one is called the type L, and L is for low elastance. Those patients, they have a higher lung compliance or preserved lung compliance. Those may be the patients that will present with poor oxygenation, but with no major respiratory distress or no major dyspnea, and they may be taking full breaths and being able to speak in sentences. Those patients may be the ones that will have poor response to positive pressure ventilation and intubation. I'm calling them here oxygen responders. Some of those patients, they will respond to oxygen delivery devices and they will improve from there. Some patients may progress to become patients that are called type H. H is for high elastance, and those patients will have low compliance. They're going to be the ones that will be struggling more to breathe. They may have more extensive consolidations, as you can see in the picture. And those patients will likely require higher levels of PEEP. They will be more PEEP responders, and they will not respond to oxygen only. In their article, they also suggested some principles to be kept in mind when managing these patients, which are to know that the initial stage is oxygen responsive, and some patients will stop there and get better. That patient L can become patient H, so these phenotypes are not mutually exclusive. Also, patients that are non-oxygen responders, there are 2 things that can make everything worse, which is forceful breathing, causing what they're calling PCILI, or patient self-inflicted lung injury, or if the patients go into a high output state with agitation or fever, for example. The progressive stage or the later stage will likely need to be treated with higher levels of positive pressure. And if patients need to be intubated, they may need deep sedation and possibly paralysis shortly after intubation. So this is an algorithm that I put together using different algorithms, trying to keep it as simple as possible. So when assessing these patients, the 2 main things we have to look at is, number 1, their level of hypoxemia using a pulse ox or an arterial blood gas. And the second thing is their work of breathing or effort of breathing, which can be assessed based on respiratory rate, accessory muscle use, if the patients are able to keep a conversation, or if they are shallow breathing already. And the terms happy hypoxemic or struggling hypoxic, they are not my terms. They have been mentioned by several experts. So the happy hypoxic patient will be the one that has levels of hypoxia. They're variable. They can be as low as 70s. However, they are talking to you. They don't look like they are in distress. The recommendation is that these patients should be tried initially on oxygen with a nasal cannula or a face mask, and even progressively to a non-rebreather mask if necessary. And if they're responding and their oxygen saturation is maintaining between 92 and 96%, you should continue to closely evaluate them, especially paying attention to their breathing effort. The patients that present with more struggle to breathe or struggling hypoxic, they should certainly be tried on oxygen delivery devices, which could progress from a nasal cannula to a face mask, non-rebreather, or to a high-flow nasal cannula, which will provide more flow, and with a short reevaluation to see if their dyspnea improved. Not only the oxygen level improved, but if their effort improved, yes, then you should consider maybe keeping them on a high-flow nasal cannula or whatever device you're using to provide them all that FiO2, and with very close evaluation. If they did not respond to any of those measures, then those patients will probably need some type of positive pressure. They may be those non-responders. Positive pressure can be given via non-invasive methods such as CPAP, BiPAP, non-invasive ventilation, or invasive mechanical ventilation. Those patients, you should have an alert so the intubation is not delayed. For the patients that are responding to oxygen, using low-flow systems is the preferred method, and this is to minimize aerosolization. So if possible, if you're delivering FiO2s anywhere from 20 to 60%, you can do that using nasal cannula or a reservoir cannula, which is called an oxidizer in most places, or a face mask that will give up to 55% FiO2. A non-rebreather mask can deliver anywhere from 70 to 90% FiO2, but we should consider that with a non-rebreather mask, it's going to be difficult for patients to wear a surgical mask, which can potentially decrease droplet production. If the patients are requiring more than 5 or 6 liters or more than 50%, you should certainly consider getting an arterial blood gas and do a quick reevaluation of their work of breathing, their potential for decompensation based on their age and their pre-existing conditions. You should start thinking about your availability on negative pressure room if they need to be placed on a high-flow nasal cannula or CPAP or intubated. And most certainly, we should discuss goals of care. These patients are going to be alone most of the time, and it has never been more important to discuss goals of care early. Here is a figure that was published with their article that shows the principles of management in relationship to the mechanism of injury, and it's very interesting. It shows more of the patient that will be the non-responder. They hypothesize that the damage is initially induced by vasoplegia, which causes hypoxemia, and then increases the respiratory drive and the forceful breathing, which puts the patients into this biliary vortex or lung injury vortex. So if they're placed on non-invasive ventilation and they improve, that should be continued. Now, if they are placed on non-invasive ventilation and with a quick reevaluation, they are not improved, they should be considered for early intubation. Now, if that intubation is delayed and they continue in this vortex of damage and they may end up needing later intubation, they will most likely need higher levels of PEEP, which can bring hemodynamic instability and more lung injury. They may need to be prone, which is something that is difficult, requires a lot of people. And they may even be considered for ECMO, which is a therapy that has been used, but it can come up with a lot of complications as well. So high-flow nasal cannula has been used widely, especially in the United States. I just wanted to highlight effectiveness versus safety topics when using high-flow nasal cannula. It is certainly best if the patient is hypoxic, requiring high levels of FiO2, but with no significant distress, with no need for immediate intubation. When using high-flow nasal cannula, we know that the flows can go up to 60, at times 80 liters per minute, which is a very high flow. So we should aim for the highest FiO2 needed and the lowest flow. And the recommended is to keep it at less than 40 liters per minute, preferably. When using high-flow nasal cannula, if you can, a negative pressure room should be used because of the risk of aerosolization, which has not been fully determined, but it's certainly a possibility, so we need to keep ourselves safe. And it should be considered in patients that choose not to be intubated. And lastly, one advantage of a high-flow nasal cannula is that patients can wear a surgical mask over it. And it has been reported to be fairly comfortable because it is heated humidification. So CPAP, BiPAP, or non-invasive is widely used all over the world. It has helped a lot of these patients. They should be considered if the patients have no obvious need to be intubated, and they did not have the initial improvement with only oxygen supplementation or hyponasal cannula. When used, you should use it with a full face mask with a good tight seal on the face. The use of helmets have been reported in other places in the world, but it is not widely available in the United States. And the circuit should have a viral filter if you have that available to you. When using CPAP, pressures can be started at 5 to 10, and you can go up to 15 or 20. Normally, pressures higher than that would be uncomfortable because it is a continuous pressure. BiPAP can be used for support of patients that are hypercapnic or patients that need it simply for more comfortable breathing. Most patients with COVID-19 that will present to CPNIC will be hypocapnic, but BiPAP can be certainly used. And they should be frequently monitored. This therapy should not delay intubation. If the patients are started on non-invasive ventilation, an arterial blood gas should likely be obtained every 1 to 2 hours initially to determine if they're improving or not. And those therapies, along with hyponasal cannula, they can be used with what's called awake proning or awake repositioning. So awake proning is not a new idea. It has been talked about in the past, but it's now regaining popularity with COVID-19, along with the idea of repositioning with changing position every so often. We don't have any strong evidence on this yet, but I'm sure we're going to start seeing more case reports or even bigger studies because it has been progressively more used over the last several weeks. It has been shown to improve oxygenation and the distribution of ventilation perfusion as you shift things to the areas of the lungs that are still healthy and not affected by the virus, especially when combined with hyponasal cannula or non-invasive ventilation that will provide more FiO2. If you look online, there are some protocols that can suggest how to do this, and obviously it should be done safely if the patients are able to comprehend your instructions and if they are not in obvious distress without need to be intubated immediately. This should certainly not delay the need for intubation. So a few scenarios when early intubation should be considered. If patients are hypoxemic and struggling to breathe, if they're having that forceful breathing and using accessory muscle use, if they have persistent tachypnea and dyspnea despite getting large amounts of oxygen or non-invasive ventilation, and also if they have what are called the poor prognosis labs, which indicate that they may be going into that cytokine storm. This was also covered by Dr. Song on a prior lecture. Some of them are an elevated D-dimer, the procalcitonin, the CRP, the LDH, and elevated ferritin levels. Those are mostly inflammatory markers. So despite the fact that we still don't know if this disease is ARDS or is somewhat like ARDS, the recommendation is still to use principles that we have learned from larger studies on ARDS, which starts with protecting lung volumes, using 6 to 8 mLs per kilogram of ideal body weight and not actual body weight, using a respiratory rate anywhere from 14 to 22, and it may be as high as 35 if needed because of hypercapnia. The use of PEEP is the most controversial piece here. For non-PEEP responsive patients, general recommendation is that they may need PEEP anywhere from 5 to 10, may be enough for them. For patients that are PEEP responsive, there are different protocols being used. The recommendation by the Society of Critical Care Medicine several weeks ago was for the use of the high PEEP lower FiO2 table from the Artsnet Protocol. This has been extremely controversial. The use of PEEP should definitely be guided by improvement in oxygenation and also lung compliance, which we'll talk about in the next slides. The third would be paralysis for patients that are still hypoxemic despite sedation, and also for patients that may be desynchronous on the ventilator. And lastly, pruning has been shown to improve mortality in ARDS in patients that have severe hypoxemia with a PF ratio of less than 100 to 150 when done for 16 hours a day. Pruning can be very complicated. It requires a lot of coordination and a lot of staff. but it has been shown to improve mortality in ARDS. So if the resources are available, this should certainly be considered for the COVID-19 patients. In ECMO, I'm not going into details about ECMO, but it has been used in several places in the world. If none of the other measures have worked, it is obviously decided on a case-by-case basis because ECMO can come with a lot of complications. Here is the Artsnet Protocol, just showing the lower PEEP, higher FiO2 table and the higher PEEP, lower FiO2 table. And here are some suggested initial ventilator settings and goals that I have combined. So as far as mode of ventilation, no mode has been shown to be better than the other. The suggestion is to use volume control, so assist control, volume control, so you can control how much volume the patient is getting. We already talked about suggested tidal volume and respiratory rate, and your FiO2 should be the lowest possible, depending what kind of table you're using, a lower PEEP or a higher PEEP, and how your patient is responding to positive pressure. The goal oxygen saturation should be anywhere from 88 to 96%. We don't have data on this. This is just extrapolated from prior recommendations. PaO2 anywhere from 55 to 80. And permissive hypercapnia has been used, trying to keep a pH anywhere from 7.3 to 7.45. Your plateau pressure should be kept at less than 30 to avoid ventilation-induced lung injury. We should watch for hemodynamic stability. Some experts say that your vital signs should be the same vital signs shortly before intubation to after intubation. And adequate sedation should be considered to make sure they decrease that breathing efforts, that forceful breathing. Since we talked about using lung compliance to see how the patients are doing after being intubated and placed on mechanical ventilation, here are two ways that we can assess lung compliance using numbers from the ventilator. The first one is plateau pressure that should be kept at less than 30. Plateau pressure can be obtained using an inspiratory pause on the ventilator. And if you have a plateau pressure that is greater than 30, the suggestion on adjustment of your tidal volume is to increase it by 1 ml per kilogram of ideal body weight, going as down as 4 ml per kilogram. And if your plateau pressure is less than 25, and your tidal volume is less than 6, meaning that you have a good lung compliance with the protective lung volumes, that means that you can still have the chance of increasing your tidal volume if you need by 1 ml per kilogram, so slowly until either your plateau pressure is decreasing to 25 or approaching 30, or your tidal volume is 6 or even 8 ml per kilogram, when you should reevaluate and see if the tidal volume needs to be. Obviously, those patients will likely need serial arterial blood gases for close monitoring. Another very important concept is something called driving pressure, which is a calculation of the plateau pressure minus PEEP, so numbers that you can obtain from the ventilator, that should be kept at a goal of less than 15. So the concept of driving pressure has been studied more and more over the last several years. There was a pivotal study from Marcelo Amato in the New England in 2015 that showed a correlation of lower driving pressure with improvement in survival. So this is something that we should really keep in mind. It's easily calculated and can be done at bedside. This is just a schematic of escalation of treatment if patients continue to be more hypoxemic. Since we talked about intubation and mechanical ventilation, I thought it would be important to talk a little bit about sedation and analgesia. There is no specific published data on COVID-19 on sedation and analgesia yet. Some considerations that are important to keep in mind are that some patients will be extremely dyspneic right before intubation, so they may require deep sedation and even paralysis, not only to improve their hypoxemia, but to improve their synchrony with the ventilator and their comfort. However, a lot of these patients are staying on mechanical ventilation for several weeks, so we need to keep that in mind when deciding which medications to use, because a lot of those medications can cause harm in the long run. So obviously, this should be decided on a case-by-case basis. So just a few highlights on the most common ones that we use. We know that benzodiazepines can cause delirium, especially in patients that are elderly or with longer periods of usage. So the use should be minimized, and if possible, it should be kept to PRN pushes and not continuous infusions. We should remember that propofol, when used for more than 48 hours, can cause hypertriglyceridemia, which can be complicated by pancreatitis. So patients need to have their lipid levels monitored if they stay on propofol for several days. Opioids, obviously, they can cause dependence. PRN pushes are preferred other than continuous infusions. And we should consider other available medications such as dexmedetomidine, the use of melatonin, and also atypical antipsychotics, making sure to monitor QTC if it's needed, and the use of acetaminophen for pain. And just one thing to remember, if patients are paralyzed, either with continuous infusion or with pushes, they need to be sedated. And we're starting to see some data on delirium in COVID-19, also some CNS issues in post-ICU illness. So I think we have a lot of more interesting data to come on that. So I wanted to share with you this picture from Dr. Wesley Ely on his Twitter account. He is a big advocate to minimize sedation when possible in the ICU to prevent delirium. And he posted this picture of a patient with COVID pneumonia on 70% FiO2 and a peak of 14, and the patient was writing, so she was probably either not sedated or minimally sedated, and she was writing to him about a scary dream that she had, and then she started crying and progressed to desaturate. But she said that she was thankful that she was not heavily sedated so she could still communicate. So this is just an example that patients will be different from each other, and the decision should be on a case-by-case basis. We should definitely keep in mind that these patients may stay in the ICU for a long time, such as this patient that was on a 70% FiO2 with a peak of 14, with probably a long ways to go. So the recommendation on fluid management for patients with COVID-19 has been to use a conservative or perhaps a restrictive approach, and reserving fluids to patients that present with hypotension, shock, or patients that are obviously hypovolemic. And this recommendation is based on data that we have for ARDS. There was a trial years ago called the FACT trial that showed that patients with ARDS that were mechanical ventilation actually did worse if they were volume overloaded. When using fluids for COVID-19 patients, the recommendation is for balanced crystalloids with either plasma light or lingers. So that normal saline can be used as an alternative. And we should avoid large boluses and avoid keeping patients on maintenance fluids. If they are still hypotensive and they need vasopressors, norepinephrine is the first line. So the use of steroids has been extremely controversial. We so far don't have any strong evidence of harm or benefit. There was a small study with 200 patients in China that showed an improvement in mortality in patients with ARDS that received methylprednisolone, but apart from that, we still don't have any other major studies. The hesitation with using steroids comes part of it from data from influenza that shows increased mortality. So apart from the situations where we would normally use steroids, such as an asthma, COPD exacerbation with bronchospasm, refractory shock, or patients on chronic steroids that may develop adrenal insufficiency, the official recommendation to use it in COVID-19 has been controversial. Here is the recommendation from the major societies that I highlighted for you. The Society of Critical Care Medicine recommends to use refractory shock, as we mentioned, and we have been using hydrocortisone for those patients now for a while. And for patients with ARDS, with COVID-19 and on mechanical ventilation, they recommend using dexamethasone 20 milligrams daily. The recommendation from the NIH is fairly similar. They recommend to avoid steroids unless ARDS or refractory shock. and the Infectious Disease Society of America is recommending only with ARDS in the context of a clinical trial. Empiric antibiotics are also a topic that we don't have much data on so far. We know that the superimposed bacterial infection has not been reported very commonly. However, these patients are staying in the ICU for a long time, so I think we are probably going to start seeing more data on this. Prior data on MERS show that about 18% of critically ill patients had a bacterial infection. So the official suggestion is that it is reasonable to start empiric treatment, especially for patients who present with pneumonia or more severe case, with special attention to patients that were initially improved and now present with worsening fever or worsening cough. The suggestions that I gathered here to highlight for you is that they're probably not indicated if patients are not hypoxemic and hemodynamically stable. Those are likely that patients are even hold off on antibiotics. And they're likely indicated if they're hypoxic, hemodynamically unstable, or if they have reported airway secretions. The community-acquired pneumonia or hospital-acquired pneumonia regimens should be the ones based on your institution or as per your guidelines. And prior to the escalating antibiotics, when they stay in the hospital for a few days, you should consider a few things such as the results of all the cultures, and including an MRSA PCR results, if you have started them on MRSA coverage, the white blood cell count, leukopenia or leukocytosis, especially the trend, comparing to their admission numbers. Also, a comparison of procalcitonin level from their admission to the day of discharge or the day they were deciding on antibiotic de-escalation, and also their risk factors for multi-drug resistance. Now moving to some other ICU-related issues. So I just wanted to touch on VTE prophylaxis or DVT PE prophylaxis on patients that are admitted to the hospital. The idea of endothelial injury causing a hypercoagulable state has been now accepted widely, and different studies and case reports showing patients having thrombotic events or strokes, etc. And the development of this coagulopathy has been associated with poor prognosis as well. So the general recommendation is for VTE prophylaxis pretty much universally with low molecular weight heparin or unfractioned heparin if they have a creatinine clearance of less than 15. If they have active bleeding or any serious recent bleeding, they should be withheld. And if they have a history of HIT, then the use of clonopharynx can be considered. A recent study showed that in patients with COVID-19 that had sepsis-induced coagulopathy based on their coagulation labs, being on VTE prophylaxis with Lovenox or infection heparin actually improved their survival. Here is an algorithm from the International Society on Thrombosis and Hemostasis that you can use for your review later. Some other considerations to keep in mind when patients are in intensive care is that central vascular access should be obtained early if possible if the patients are going to be on pressors or multiple infusions, or if they have an unreliable peripheral line. Also, for arterial line, if they're going to be needing arterial blood gases, it may be important to get one, even if they're hemodynamically stable. You should avoid nebulized breathing treatment when possible because of the aerosolization and exposure to staph. And when patients are extubated, this should be also very well planned. So not only intubating them requires a lot of plan, but also extubation, because it's a procedure that it's known to be aerosol producing, and as you know, a lot of patients have cough, not only the moment of extubation, for several minutes after. And lastly, I just wanted to share with you the FDA approval of remdesivir for emergent use in patients that have severe disease with COVID-19, which they defined as hypoxia with an oxygen saturation less than 94% on room air, patients that are requiring any supplemental oxygen, that are mechanical ventilation or ECMO. here are my take-home points. So just going to go over them briefly. COVID-19 critical illness is related to hypoxic respiratory failure that can progress into multi-organ failure. This is likely not typical ARDS, since we're seeing patients with profound hypoxia with minimal dyspnea at times and also extremely prolonged periods of mechanical ventilation. Much more information needed here. Some patients will respond to oxygen only. If they don't have increased breathing effort, you should not rush to intubate them just because of the hypoxemia level. And if the patients are very tachypnic and not responding to oxygen, you should consider a trial of high-flow nasal cannula or CPAP with very close observation so intubation is not delayed. If they have to be intubated, you should use protective lung volumes and watch their response to PEEP. Again, much more information needed on that. We should balance sedation and analgesia since they're going to be staying in the ICU for prolonged periods of time and may need to be in mechanical ventilation for prolonged periods of time. We should be conservative, sometimes restrictive with fluids. Steroids should be given to patients with ARDS and mechanical ventilation. Antibiotics should be considered for patients with pneumonia. And universal ETE prophylaxis unless they have a contraindication. And with that, I conclude, and I thank you for your attention.